morning. So, I'm quite honored to welcome you all because what I see around me are not only experts but my colleagues who've flown many miles to be here to share the experiences and to really further this cause of gender. I think which impacts not only many in India but globally. So thank you, Roxy and Michelle and many others, Zoe and others who've flown down. I want to warmly welcome all of you, the panelists, all of you who've taken out time on this Friday to be with us, and those who've joined us online. Um, for Vital, as an organization, those who do not know, we've been working on public health as a central, theme of our work to really see how can we reduce death, disease, or injury in any form. And when we look at public health and our work, whether it's around non-communicable diseases and climate health, mental health, and many forms of these problems, central to all this work is our work on gender. So clearly, as an organization, we recognize the importance of understanding the importance, as Roxy said, about mainstreaming gender, and to be able to take this agenda forward. The approach Vital generally takes and has been taking with the help of our partners, Bloomberg Philanthropy, Johns Hopkins University, UNESCAP, and many others, is to see that how can data be used as an evidence to drive effective policies. How can you really create that data into knowledge? How can you really create it into a policy brief, which can actually drive this whole agenda for the governments and strengthen their, the capabilities to address this important issue. So to mainstream gender and to make sure that it is actually at the center of not only our work in India, but globally wherever we work with the partners. We recently conducted a training where we had participants from 6 countries. Many of them are here in this audience today, and I welcome them as well for coming from as far as Papua New Guinea and Philippines, and we had Sri Lanka right here, and our friends at IIHMR, in partnership with whom we did this in Delhi. And over the 3-day period, they came out with ideas and areas they wanted to address on the gender thing, whether it was gender HR allocation or gender HIV or gender NCD, and there can be multiple forms of these problems which can be looked at. And so with that data and our teams here, many of them are here, who actually help them to understand and see how can this be converted into practicable areas where a policy brief can be prepared or a knowledge product can be generated. And we believe this is important because to further this whole agenda of mainstreaming gender and making sure the health policies actually keep it at the center of it, it needed to be able to understand where are those challenges and how do we do it. So I'm hoping the training which happened through these participants, we will go ahead to strengthen those countries where they came from and the capabilities to actually then make policies which are effective for mainstreaming. And so finally, my view is that we all know the 17 SDGs, but we tend to forget that the 17th one, which is really about partnerships, to me is the most important. I think in a world where you're looking to solve problems of magnitudes which are so dimensionally different, even as a gender concept, you look at it, it's got psychological issues, it's got social issues, behavioral issues, so many undercurrents which run. I think to be able to solve problems of that magnitude, you need partnerships. You need partnerships with the academia, with the participants on the ground who come out with the learnings, with the policy makers who can understand that, look, what kind of work will actually drive this? And I think we sit right in the middle where we want to take those learnings coming from the ground. We want to help the governments to be able to make sense of all this data. So I would encourage you all to, to learn, to share, to participate and share your experiences. And by the time you go back, I hope you would have built new friendships and new partnerships, which can actually further this important cause. So thank you, Roxy, and thank you all. And I hope you have a good session today. Thank you.
Thanks, LM, for providing the context around this important topic and for also raising this important issue around partnerships, which I think we all need especially as we become more connected as a global health organization or global health. Um, so now I want to move on to the panel discussion, and I want to ensure that this is an engaging conversation. So we want to hear from the panelists, but I also want to hear from all of you in the room and those of you online. So we will have a Q&A session after the panel. And so if you have any questions, please take note of that. For those of you who are online, I ask that you type it up into the chat, and we'll try and get through as many questions as we can after the panel as well. So without wasting any further time, I'm going to call up the panelists. So I'll start with Kanta Singh. And I was saying that I have a mix of professors and doctors, and so I'm just going to call everyone by their first name to make it easier for me. And Kanta Singh is from the Deputy Country Representative from UN Women India. Thank you so much, Kanta, for joining us. Next, I want to invite Michelle Kaufman to the stage. She's an Associate Professor and Director of the Data for Health Gender Equity Unit at Johns Hopkins Bloomberg School of Public Health. Thanks, Michelle. We also have Chloe Harvey with us today. Chloe, welcome to the stage. She's the Associate Population Affairs Officer from the Statistics Division in the United Nations Economic and Social Commission for Asia and the Pacific. And we often talk about it as UNSCAP, so you might hear the abbreviation UNSCAP as well. With that, I want to invite Ravi Verma, Regional Director for Asia at the International Center for Research on Women, and Adriel Pizarra, Medical Officer 4 at the Philippines Department of Health. And I see you're keeping me on my toes. Everyone's selecting alternate seats here. And then finally, we have Vindya Kumarapeli, a Director of Policy Analysis and Development at the Ministry of Health in Sri Lanka. Thanks so much. Anyway, maybe sit in the middle. Oh, you want to sit? No, perfectly fine. Don't worry. So I'm going to sit at the end, and I'm going to start the conversation with Michelle. So Michelle, I want to start with this issue of gender mainstreaming. And as I mentioned in the opening, we're often hearing this term, but I think for many of us, we assume we understand what it means. But I want you to unpack that a little bit. Tell us what does it mean? What is the vision behind gender mainstreaming, the term, and how are we encouraging that within policies or within health as well? Thanks.
Thank you, Roxy. So when we talk about gender mainstreaming, the ultimate goal is gender equality, right? But gender mainstreaming is a strategy to get there, a strategic approach, where we are tasked with considering gender in all aspects of programmatic or policy development. So this might include ensuring that women have a seat at the table around decision making, that budgets include sufficient funding to address gender issues, ensuring that in policy or programmatic development, design, implementation, evaluation, and monitoring, that gender is considered all along the way. And if we do that, if we pay attention to gender and how policies and programs affect men and women differently, or I would even argue in other contexts, gender diverse people, if we are thinking about that all throughout the process, then we inch closer to true gender equality. I would also argue that gender mainstreaming is the process, but we need to go beyond that and looking at gender transformation, right? So we can be attentive to gender through this mainstreaming approach, but if we aren't engaging in policy change, programmatic development that is truly trying to transform harmful gender norms and cultural practices, then we're never going to get to gender equality. So that transformative approach as part of gender mainstreaming uh, in my view, and a lot of gender experts will talk about this, is really the key goal.
Thanks, Michelle. And we also want to hear about some of the work that you're doing in the Gender Equity Unit at Bloomberg School of Public Health.
Certainly, yes. So I direct the Gender Equity Unit. We are a part of the Data for Health initiative funded by Bloomberg Philanthropies. And our goal is to ensure that all people, all genders are counted in health data systems. And so we are working across the Data for Health initiative to ensure that health data systems and any policies or programs that are being informed by health data are inclusive of all gender. So we work with countries to provide trainings and technical assistance, research support to ensure that gender is an element in all health data practices.
Thanks, Michelle. I'm going to move over to Kanta. Kanta, in terms of UN Women, what have you been doing in terms of, strengthening gender mainstreaming, especially with this focus in the health environment? And what are some of the challenges that you are seeing, you are facing when you're sort of doing this work?
Thank you, Roxy. Morning, colleagues. All of you probably understand that UN Women doesn't work on health. There are 2 or 3 specialized agencies in the UN system, including WHO, including UNICEF for Children, and also UN FPA that work with women's health particularly. But UN Women, since it is the specialized agency or specialized entity for gender equality, health of women concerns us as well. And UN Women works in multiple ways, Roxy. One being the policy environment, where we look at the budget in India particularly. We look at the budgets and spending. So we work very closely with Ministry of Health, build capacity of the officers in planning and designing, and also allocating resources for addressing the differential need of women and their health. So that's one part of the work that we do. Gender-based violence and its implications on women's health and the economic and productive lives is a flagship program for UN Women across the globe. In UN Women India as well, we take care of that thematic work, and we take it very seriously. Some of the partners like Ravi are sitting here, where we look at the survivors of sexual violence and gender-based violence online, offline. Also, again, building capacity of the officials across the country in multiple states in the Ministry of Women and Child Development. We design policies, we design interventions, do a lot of work in that space. Also, cyber violence. We have started focusing more on cyber violence. Third, as I said, capacity building of duty bearers, particularly, including Department of Justice officials. Last would be implementation, and we do multiple things there. During COVID, we took little more, time and budgets from our core money to train 10,000 nurses, for example, to care for survivors or care for COVID patients. We also work with ASHA and Anganwadi workers and the one-stop center staff. We work with we work in tea gardens where we look at the workers' mental and physical well-being and health issues. We also work with the spices sector and also textile sector. So there are multiple ways in which UN Women work. But in terms of mainstreaming, wherever we are, and if health issues are being discussed like today, our concern would be how are you taking care of women's needs and women's specific interests. And also putting women in leadership positions across sectors is also a key area of work for us. And I'll stop here.
Quite an expansive set of activities, as you said, really connects to health both directly and indirectly. Do you want to mention just maybe one challenge? I know you covered quite a lot, but maybe just then the most important that you see.
Most important in India, if I want to talk about, is investment. There's not sufficient investment in health. Of the total budget that government spent in 2021, that's the latest figure I have, only 30% of that was spent on women. And women constitute 50% of the population. So that is one. Data being the big, another challenge. Without data, evidence-based policy making is not really been done here. Thirdly, I think the challenge is awareness levels amongst women to seek health services as per their requirement. Reproductive health remains a concern, even though it seems moving, but those are some of the challenges that we see.
Thanks so much, Kanta. Ravi, I'm going to hand over to you. So I know UNSCAP has been doing quite a bit of work on civil registration and vital statistics. Now, I know some in the audience may not know what CRVS is, so we're curious to hear a bit about the civil registration and vital statistics system, but also how does then gender mainstreaming or gender fit into that?
Thank you very much, Roxy. So across the UN system and also at ESCAP, gender mainstreaming is becoming increasingly integrated across all of our work programs, but it does have particular importance for CRVS. And I'll start off by defining CRVS. So it stands for Civil Registration of Vital Statistics. And civil registration is a permanent and continuous recording of vital events. And by vital events, we mean births, deaths, marriages, divorces, and other vital events. And vital statistics are statistics produced using civil registration records that should be ideally produced regularly. So we know that complete, accurate, and timely production of vital statistics and civil registration is fundamental for ensuring that women, girls, and other marginalized and vulnerable population groups are visible in population-based statistics. So when looking at it from a life course perspective, applying a gender lens is critical from cradle to grave. And by that, I mean from the very start of life with birth registration to marriage and divorce, and then towards the end of life with death registration. And we do see that women face critical barriers and structural impediments to registering their vital events from birth and throughout their lives. And it also has intergenerational impacts. So to give you one such example, women who perhaps don't have their own birth registered, or perhaps they don't have their marriage certificate, or maybe they're unmarried, they won't be able to register, they might not be able to register the birth of their child, and so then the cycle just continues onwards. But we also see in the Asia and Pacific region that there are distinct inequalities in death registration, whereby women are less likely to have their deaths registered. And this is usually due to a lack of incentives, as women usually have fewer assets than men. But we also know that there are also distinct differentials in sex differentials in patterns of mortality. So we need this data for gender responsive health programming. And I think I'll just end by saying a little bit about what we're doing at ESCAP. So at ESCAP recently, over the past few years, we've been supporting countries in Asia and the Pacific to conduct inequality assessments to try and identify which population groups are being left behind from civil registration. So we hope that over the next few years, more data will be generated to see exactly who is being left behind. Thank you.
Thanks, Chloe. So a lot of work in the region, but also hearing about work in India from Kanta. Ravi, I'm going to be a bit cheeky. And I'm going to ask you, as one of the males on the stage, how do we get more males? Gender mainstreaming is starting to feel like a female conversation. How do we get more males involved in the conversation or build more male leadership in this space?
Thank you. Thank you. I think, thank you for having me here first. And it was so good to listen to Michelle and Kanta and my colleague there. I'm picking up a few threads from what they said. You know, I think before we say how to engage men into this, we have to take a step back and look at what the health system is like. And on the top of my head, at high level overview, I think there are three important pieces within the health system that need to be introspected, corrected, sort of addressed. One is a misconception, and one is a misconception between sex and gender. A lot of the entire health system and health literature and health professionals use these two terms almost interchangeably and conveniently. We know in the gender sector that sex and gender are two very different constructs, but we also know that they are used conveniently to either skirt the issue around gender or reinforce the binary in some ways because that suits the health system. So that's one. I'll not. We can have a longer discussion on this, but I think the most prevalent misconception is the interchangeable use of sex and gender. Second most common problem in my view in the health system is a overlap between gender and women. So we always, when we use the word gender, we mean women, and it's always it's so prevalent in health system that we have not been able to address this issue of conceptually at the framework level to address this misconception, misnomer, misuse of the term gender equivalent to women while addressing the issue of health. And we know all the data that emerged that how men have been far more contributed to the overall burden of disease. In last 15 years or so, the entire disease has shifted in favor of the causes that are very masculine oriented. But anyway, I mean, it's because gender, and data is not even gathered around that. So that's second. The third driver of that drives health system, in my view, in our view, in many of people whom I work with, is how knowledge is created in health system. It's very top down. You know, the knowledge creation, knowledge management is driven by largely RCT kind of, I'm not opposed to RCT kind of a model, but I think the very quantitative health system is so quantitative and so top down in defining people in terms of averages and statistics and you know, as if there is no context within it. We decontextualize human beings. So we in health system we don't really regard diversity. We find one size fits all. You know, we have seen COVID time. We have seen every time. Why to give example? I think this audience should be knowing, and all of us are converted. I'm sure you know how health system has used the knowledge, the methodology of knowledge creation to homogenize people. If that is the approach of the larger health system, you can't mainstream gender. You can't engage men into this discussion. You know, so that's one. I mean, I just really want to put it up front. If we have to engage men, we must really be prepared to face some of these larger questions that we have never addressed. We have conveniently skirted them around. We have continued to publish Lancet kind of publications, which is extremely biomedical, and just value those that draw upon certain kinds of and there's no disrespect for those publications, and they are good. They set the standards. I think the utter disregard for the local, contextual, decolonized ways of understanding health and how it impacts the diverse groups of people has not been at the center of health systems. So that's one. Now, how to address men, how to engage men into this? So obviously, the first thing is to change the discourse within the health system about gender by bringing these perspectives. Two, by pushing a lot of women leaders in health system. We have just completed a study across 2 continents, and we have seen how pathetic is the condition of of women leadership in the health system. There's literally 70% of the workforce on the ground is women, and then you have no leaders who can change the system in a way which is equitable and diverse and inclusive. So if men have to be engaged, women have to be engaged much more aggressively to become and come into the leadership position and begin to challenge those gender norms. But the care that we need to take is that we don't reinforce the binary, men versus women. We bring women into the, the system needs to bring women into the leadership position and be also mindful of diversifying the gender spectrum. So that's the second piece. And third, final, before I stop, it's not final, there are so many, but I really think this is important from my perspective, is that there is a lot of research and a small bouquet kind of a piloting and research leading to programs on the ground that suggest how to change the demand side of the health system. And because what health system does is mirroring the society. Our health professionals are really the mirrors where they live in. They are reflecting what they think. If you ask a family planning worker out there, they would invariably tell you that it's a women who want to be pubectomized and they don't want their husbands to be vasectomized. It's so easy to put the blame or put the onus onto the women for any decision that is reinforcing patriarchy in some ways. So it comes from the society into the system, and therefore there has to be engagement of men changing discourses on gender relations, gender norms within the communities of health system, in that ecosystem of demand side. I'll just stop here. If there is an opportunity, I'll like to.
Thanks so much, Ravi. Vindya, I want to hear a bit more about Sri Lanka. What has been some of the successes you've seen in Sri Lanka? And if you've faced any challenges, how have you overcome this in Sri Lanka as well?
Thank you very much. So, in Sri Lanka, there have been several initiatives to ensure gender equity. So, firstly, I would like to mention that in our country, the government provides free health to all citizens. So, that has ensured equal access to healthcare services, both men and women, and so does not exclude women. So that is one thing, and as it is free, so there's no financial hardship specifically for women. So it's equally free for both men and women. And then I also like to mention that the Ministry of Health, Sri Lanka has several policies and programs specially targeting women. For example, we have a bureau and a program for maternal and child health services, which provides all services related services, antenatal care, postnatal care, family planning, and screening for cancers through well-women program. So this has actually, I would say, resulted in better health for women. Second point is there are specific programs and policies targeting women from the Ministry of Health. And we are a small country, but we have a very extensive network of hospitals and field clinics. Both curative and preventive sector services cover the entire island, and within a reach of, I would say, 5 kilometers radius, anyone can reach a primary care hospital. And so I would say that again has given equal or easy access to both genders, but maybe it has made it easier for women, especially maternal and child health clinics, field clinics, immunization clinics, so that as a result of that, we have one of the lowest maternal mortality rate in the region. And I also like to commend the work of the field workers. We call them public health midwives in our country, as they are entirely women. So the public health midwives reach the remote and rural women, and they reach the most vulnerable, disadvantaged women because they go to households. And as mentioned, even the tea plantation sector, which has a lot of problems, majority are women. So as a result of these community health workers in the country, funded by the government, there are a lot of positive effects that we see in terms of women, and I would like to mention that in Sri Lanka, the female literacy rate is 92%, and women enjoy longer life than men. Life expectancy at birth for women is 79.5 years, whereas for men, 72.5 years. So, but there are challenges. So, we do face the same challenges of traditional gender role in our country. So as I mentioned earlier, the remote and rural women have issues with seeking care. And there are unfortunately extremist religious and ethnic groups that prevent women from getting family planning services. And I like to mention also one issue about sex education, there are, although it's in the school curriculum, it's not being practiced, and as a result, we see a lot of illegal abortions, teenage pregnancies, maternal mortality among women in our country. And finally, another challenge is actually a recent challenge. We are going through a financial crisis in our country at the moment, and although health is free, there are a lot of out-of-pocket expenditure due to hidden costs like loss of wages and transport costs. So I think women are disproportionately affected by the financial crisis also. That's from Sri Lanka. Thank you.
Thanks for those insights from Sri Lanka. Adriel, moving over to Philippines. I know there's been a lot of progress in the Philippines around gender and work in gender. What has been some facilitators of that work? And then also, what are some of the barriers you still continue to face in the Philippines?
Right, thank you, Roxy, for that question. So in the Philippines, the journey towards gender mainstreaming in health policy has seen notable achievements while also alongside with the persistent challenges. As for the facilitators, I'll start with mentioning the importance of intersectoral collaboration, our partnerships with other government agencies, especially the Philippine Commission on Women, has been instrumental. This commission is assigned or tasked to ensure the gender responsiveness of the different sectors' health plans. In terms of enabling mechanism, which is another facilitator of success, we have this law, the Magna Carta of Women of the Republic Act 9710. So this has provided us tools and mechanisms that are useful to ensure gender responsiveness. This includes gender-sensitive planning and budgeting mechanisms, as well as tools that allow us to assess the gender responsiveness of various initiatives of the department. And the last facilitator of success would be the people. So the Magna Carta of Women also further mandated the creation of what we call the Gender Development Focal Point System. So this encompasses the creation of Gender and Development Focal Point System Steering Committee, and as well as technical working groups across different units of the Department of Health. So what this does is that it ensures that the programs, policies that are being cascaded and implemented by the department are gender responsive from the top level down to the grassroots level. But we're no exception. We're not immune to the challenges that were also cited by Dr. Rabi here, as the Philippines has concerns on societal beliefs. While evolving these deep cultural societal norms, we have to recognize, shape the health behavior. For instance, Filipino men are still reluctant to access mental health services, while members of people of diverse SOGSC, the LGBTQI+ community, still continuously confront societal stigmatization. Second problem that we have is the need for capacity development. While I mentioned there's a system called the Gender Focal Point System, this majority of the members here lack proper training and guidance to ensure the gender responsiveness implementation of the different programs of the department. And third, we also experience data gaps. We are emphasizing the importance of this data because this data prove us that it is important to ensure gender mainstreaming, as this data will feed into the inputs and policies of the Department of Health across all units. So in essence, while we have made notable strides, there's still a lot of work that needs to be done in gender mainstreaming and health policy in the Philippines. Thank you, Roxy.
Thanks, Adriel. I'm going to stay with the three of you unpacking this issue around data because it's come up a lot. Kanta mentioned it, Ravi mentioned it, Adriel, you now mentioned it. So going back to Vindya, what are some of the data gaps that you are seeing in Sri Lanka, and how are you then addressing this in your country?
Yes. So in Sri Lanka, we do collect routine data, complete and timely data for the maternal and child health related or reproductive health programs. It's very timely and very quality data. But unfortunately, it's not just the maternal and child health. We do have so many other programs, public health programs and curative sector data. If I may take an example, when you talk about the non-communicable diseases, we collect data, age and sex specific data from the medical clinic, and we collect data from the OPD visits. Same situation is there for mental health conditions or even communicable diseases. We do collect data, unfortunately manually, but we don't analyze the data according to sex. That is the main issue. As a result, since we don't analyze the data at the national level for other programs that I mentioned, it is the specific programs or targeted interventions are lacking. So what I see in our country or in our ministry is that we must advocate or convince the health administrators, not just collecting is not enough. We have to disaggregate by sex, we have to analyze and interpret it and also disseminate it. For example, we have an annual health bulletin, what we call annual health statistics, published every year in a timely manner. But if you go through the annual health bulletin, it does not give the sex aggregated data. It only talks about the top 10 or top 5 leading causes. And similarly, we do have health performance reports coming up from the national programs. They don't analyze data according to the sex. So my suggestion is that this is the time we have to convince and advocate and convince the health administrators to not just collect data, but analyze and interpret according to the sex or the gender. Thank you.
Thanks so much, Vindya. Adriel, I know you mentioned that data, there's this gap in data, but I also know that you have been using data and evidence to sort of strengthen and to sort of encourage gender equity in health policies in Philippines. So can you tell us a bit more about that work as well?
Great. So in the Philippines, the commitment of the government to ensure that all policies with regards to gender is not just data-driven, but evidence-informed. So what we have is we're very fortunate to have the Magna Carta of Women as our legal basis to implement sex disaggregated data collection. So central to that approach of data-driven and evidence-informed strategies is having that disaggregated data by sex and, when applicable or feasible, gender as well. So why is this important? Because we believe aggregated data can sometimes conceal vital disparities. As an example would be in certain conditions where men have elevated risk to certain diseases, it may or may not show that these are closely tied to societal norms which encourage behaviors such as excessive smoking and drinking. Second point is on how, financially speaking, we make use of financial data that we have across the entire department. So across all Department of Health units from the central office down to the hospital and other facilities, we have the gender planning and budgeting mechanism wherein we are required to ensure that a minimum of 5% budget is allocated to gender responsive or gender related activities, policies, and programs. And for some, that is a stepping stone to ensure that the policies, programs, and projects that are being implemented for the people are gender responsive. So currently, while the Philippine team is working on developing what we call the Gender Development Sectoral Agenda for 2023 to 2028. So central to this framework is having that monitoring evaluation that feeds on the data to, to execute properly the tracking and progress of gendered health outcomes, and at the same time recommend gender-specific indicators that may or we may have not missed to begin with as we're formulating this agenda. So in essence, we cannot emphasize enough the importance of sex disaggregated data, as we believe that this is the very first step for you to be able to conduct gender analysis in your different health programs. Thank you, Roxy.
Thanks, Adriel. And then Ravi, going to you. So Vindya and Adriel spoke a lot about health within government, and often that refers to routine health data. Could include other things like surveys, but I'm interested around research. How do you think research can help to activate and encourage gender mainstreaming, globally and even within countries?
So researchers also, the bread and butter is data. So I'll just pick up from what Angel said, the significance of sex disaggregated data, and give you another example that we have been engaged in last 3 years during COVID time until 2022. We have been tracking from the data, sex disaggregated data on the spectrum of COVID disease, let's say, from testing to infection to treatment to death, or ICU hospitalization to death to vaccination. I mean, not to death, but yes. So these are the different milestones on that spectrum. And so first of all, there are very few countries that really presented sex disaggregated data on each one of these. India, the last time gave this sex disaggregated data on death was May 2020. After that, there's no public domain we don't have. In fact, only 25% countries did present data, sex disaggregated data on any one of these milestones, from testing to infection to treatment to vaccination and all. But whatever data we had presents very interesting pattern, and that is that in some, first of all, in majority of countries, more women were tested than men, but more men and more women were infected than men. That could be an artifact of more women being tested, but yet there were more men across who were treated, more men who went into the ICU kind of treatment, and more men died. So that's one level at the national, and it really speaks volume as to why this must be happening. There is a layered phenomena that needs to be understood, and researchers like us, our antenna, we began to dig deeper as to what. And then next level of analysis we did, if we take similar social and economic and political context of these countries, we found that for every pattern there's a counter narrative. And that means in similar kind of two countries, we had some women getting more infected and women getting more treated and more women dying. In the similar context, another place, more men getting treated and more men dying, and that really, so what does it show? It just says that all this the gender plays out in the lives of men and women in a given context. In a certain context where there is a far more stringent masculine patriarchal norms that put men at risk, they will get exposed, they will get infected. Whereas in another where there is a far more stringent, the care giving role for women puts them at risk and they get infected, they get treated because they are within the realm of health system, perhaps in some places. So obviously the context for defining how gender norms are shaping the the inroads of COVID into the lives of men and women in different places. But we didn't have subnational data. In fact, we wanted, we have been, for every health issue, there should be as much, not only sex disaggregated, but even geographical disaggregation data to allow how the gender norms are playing out in those contexts, which might be very different from our preconceived notions of the men and women being determined by some kind of a larger norms. No, I think these norms change. These norms begin to take different kind of a shape in a given context, because they are all about power dynamics and the hierarchies and who gets what resources and how one uses it. And therefore, the programs need to tailor themselves to address these vulnerabilities, the intersectional vulnerabilities that we have, everybody has been saying. In gender inclusion, I think the idea of how gender intersects with caste and class and other kinds of marginalization in a given context gives a very unique amalgamation of what should be addressed and what should be measured. That's what I said, decolonized ways of creating knowledge and understanding and creating data is so critical that we have just been homogenizing. So for researchers, for us, it is very important that we constantly question any data that comes by unlayering it, by saying, okay, what is hiding, what is hidden here rather than what is revealed, and see the underneath of that data to see if there are other kinds of patterns that you could find. At a very abstract level, I can say only this much, I think, with this example. But I think more and more of us who are working into this piece of as research as a tool for mainstreaming policy, our idea is to really deconstruct the idea of monolithic understanding of disease and the people, but go down and understand how it plays out.
Thanks, Ravi.
Yeah.
So I'm going to move on beyond data and evidence, but think about us as individuals. So Kanta, coming to you, many in the audience are working in the public health space. As public health professionals, what could we be doing to encourage gender mainstreaming, but also as others, as individuals, as civil society, what can we be doing?
So a couple of things that come to my mind. One, of course, what you are doing, collaborate, talk about it, communicate, reach out to more people, particularly the ones who don't know, say who hesitate to seek health services. Encourage them. Talk about mental health issues, because women never talk about mental health issues, even if they're cracking inside. So that is number one. As individuals, that is one thing that we do. Also think about women's role from reproductive to productive. Women have another side of their lives. They are not here just to give birth to children. Plenty of and thousands of women are deciding not to even get married. Forget about having children. What about them? So count them as individuals and women who also have health issues and reproductive health issues. So that is another thing that we need to do. Mothers' role as caregivers. So of course, as mothers, they will continue to think about how to support their children and anybody else in the family. But what about their economic side? What about the care work that they do throughout their lives and get burdened with that thought? So let's start thinking about those people. UN Women is doing a lot of work on care economy and care work, and want to really bring out the economic side or productive side of women's lives. Social norms, and Ravi talked about it, and there's a lot that can be done on that side. Prevention of violence, prevention of sexual and gender-based violence. I think all of us have multiple roles to play as professionals, as individuals, as family members, and we start breaking some of those stereotypes that happen in our day-to-day lives and we don't talk about it. Undermining women's body pain. Not only women undermine that, even doctors undermine women's pain. It was shocking when I was giving birth to my child. The doctor was saying, "ऐसा क्यों बोल रहे हो? ये तो सबको होता है." Do you even know what happens to a woman when she's giving natural birth to a child? It's literally a matter of life and death. And when doctors undermine that kind of pain, and they don't take women's pain seriously. So let's at least we as professionals should start talking about these issues which are not brought into light. And lastly, again, going back to data, and sex disaggregate data is very important for informed policy making and also allocation of resources. So I think there's a lot that can happen, and good that we're talking about these issues. Thank you. Also align your work and continue to include health as a major implication, I would say, for anything else that you do. A woman who's a SSG member is also involved in economic activities, but let's look at how her health is permitting to take part in the social and economic activities. So those are the things that can be done and mainstream in other work, even if it is not related to health work. Thank you.
Thanks, Kanta. Michelle, so we've been hearing a lot about, some of the successes. We've seen it from country level, we've seen it at the regional level, but globally we're also starting to see that we're also having some regression in some ways. We're seeing a lot of policies or laws that are changing, I would say, for the negative. And then why do you think this is happening? What's happening in the space, and what can we do to address it?
Well, we're talking about social change, right? And social change takes decades, generations. And when you're talking about gender, it's not just gender in adults and how that impacts their health behavior. We have preconceived notions about what a baby, how we should respond to a baby once we know what their sex is based on gender norms. And so the entire life cycle is about socializing into these gender binaries. And to be able to disentangle that and deconstruct it and transform it to something that's more gender equitable takes a very long time. And when you start to achieve that, there is always going to be a backlash, because you're now talking about rearranging power dynamics. And so I've been doing gender work for a couple of decades now. And yes, sometimes it feels like 2 steps forward, 1 step back. But I'm very encouraged, because just the fact that we're having a panel like this, just the fact that on social media, young people are talking about gender diversity and not following gender norms, and that wasn't happening when I was first in school studying gender, right? So I feel like we have come a long way, even though it might not feel like it day to day, but we have to persist beyond that backlash so that we can continue to take those 2 steps forward on a regular basis to really achieve the gender equity that we're seeking.
Thanks, Michelle. Thanks for that. And Chloe, we've been talking about the work that's happening on the ground, and we've also been talking about data and the challenges with data. One of the important ways in which we should be looking at data is tracking our progress as we're trying to make these efforts around gender mainstreaming. So how do we sort of ensure that we track it so that we can keep a measure, keep our eye on on the work that's being done, but also how do we sort of have conversations with the people who can lead these efforts, which in many cases are government representatives, because as much as we can do have these changes occurring in society, they often are the leaders of the change in a country. So how do we have these conversations and continue this work?
Thanks, Roxy. It's a great question, and I'm sorry, I'm going to go back to the same things that Ravi and Adriel and I think all of us have said as well, is that I think first and foremost, we need sex disaggregated data, and not only do we need it, it needs to be analyzed. There is data out there, but sometimes it's not being used. And this is important, not just for health policy, but also talking from the UN perspective for monitoring progress towards the Sustainable Development Goals. And I'm going to talk about it a bit in the context of civil registration and vital statistics systems. And to give you one example, well, to begin with, I'm just going to say that CRVS systems are a data source that can provide us with sex disaggregated data, which I think is something which it's really important that we take note of that, and it highlights the importance of strengthening CRVS systems. But to give you an example in the context of the Sustainable Development Agenda, out of all of the SDG indicators, a total of 67 can be estimated using CRVS data. And out of 54 gender-related SDG indicators, 34 can be estimated using CRVS data. So I think this really kind of shines a light on the importance of CRVS data for monitoring progress, not just towards the SDGs, but also for health policy and planning and other areas as well. But I also think that as data users, it's really important that we are using data, even if it's not perfect, and that we are disseminating this data, because the more that we use and disseminate data, it creates a positive feedback loop, which means that more data will be produced. In terms of the second part of your question, in terms of promoting this work with governments, I think it's important that as development partners, we support governments to be able to identify where are the existing data gaps, and then also for supporting capacity building of national stakeholders to analyze and disseminate that data. I think from the very start, it's important that data users and data producers are involved in the production process of statistics from the very beginning, so that they can inform on updates. And as development partners, we should also be supporting governments to be using data like we did this week during the workshop for policy development, programming, and advocating for gender equality. I think I'll finish off just by saying that I think it's also important that we do remember that often the most marginalized and vulnerable population groups are those that do remain invisible in our societies. So I think it's important that as development partners, but also as governments alike, that we create a space for civil society organizations and members of the community to be involved in that decision-making process. Thank you.
Thanks. With that, I'm going to thank the panel and open it up to you as the audience, because as I said, I want to hear from the panelists, but I also want to hear from you. So if anyone has a question, can you raise your hand? Can you tell me who you are? So just your name, where you're from, if you're from a particular organization. If you want to direct your question to one of the panelists, you're welcome to do that, but you're also free to ask it, and we'll see who wants to respond to it as well. Thank you so much. Can we just get a mic? I'll come to you and then to you. I just want to see if there's any questions online as well. Okay, not yet. Okay, if you have any questions for the online audience, please put it into the chat. We won't be unmuting you, so we'll be only receiving questions through the chat. Thanks. Over to you, our colleague.
Thanks. My name is Rimjim. I'm from Engender Health, and thanks for a very rich discussion. It's a very useful discussion also. But I think it kind of also brought out the barriers that we are facing currently, because we are working on a number of gender mainstreaming projects with the government, with health systems, and in a number of other policy and project programmatic areas. And one of the main things, one of the main challenges that one faces, which is what I wanted to ask any of the panelists who would like to respond, is that how do you overcome the fact that the gender mainstreaming is typically carried out in a program or a policy where the target is something else entirely. So they are totally focused on something else, on building quality systems and quality assurance and all of that, for a target which is totally separate. And then they feel that gender is, it's not required. Why are you talking about it? This is a universal program which we are implementing, or a policy which is completely non-discriminatory. And where is the data that everybody has been talking about to be actually able to prove it, that it's not just assumptions that we're talking about, but here is the data to show that those invisible, marginalizations are taking place when this homogeneous approach is being adopted. So I think that's what I wanted to just ask.
Thank you so much. I think I'm going to take a second question and then go back to the panelists. I think we had a question over there.
Hi, thank you for the insightful discussions. When we are talking about health and the data, we can't ignore.
Do you want to introduce
So,
yourself?
sorry, this is Anand. I am working with PATH and looking after the monitoring and evaluation thing. So, when we talk about health and the data, it's not about the public health, it's the private sector plays a very important role. And we do have our limitations and challenge in accessing those data and asking the private sector to report on certain diseases until it is notified by the government. And I think beyond basing that data, it would be very difficult to gross estimates or plan things, because there is a huge chunk private sector players play important role in the health. So what measures which we could take at the country level or the government can take, so that we have the complete data of diseases, gender disaggregated, sex disaggregated in whatever way. Thank you.
Thanks so much. I'm not sure if anyone wants to take the first question about how, sometimes you want to try and have the conversation with gender, but it feels sometimes tangential, and how do you bring that forward? Michelle, it looks like you have something to say.
Yeah, so I would argue that gender underlies everything we do in our daily lives, in our work, how we interact with others. And so to say that something is not affected by gender in some way is ignoring the reality of our daily lives. And there have been a couple of good examples of this that I've read recently. One being like urban planning, right? We think that's a gender neutral activity. But if you look at the data of how transportation systems work, where they go, which neighborhoods, which communities, who uses them at which time of day, you start to see gender elements in that. And if you're not collecting data on the impact of that planning or policies on gender, you'd miss it completely, right? And there have been communities that have shown that the way city planning has been done actually is harmful to women because they're going into neighborhoods that are unsafe, or they're having to travel further distances and are responsible for domestic duties, and things that if the planners are male and are making those decisions, they might not even think about. But when you mainstream gender and you have women at the table during that planning process, during that decision making, you get a more diverse perspective on what is needed. And so that's just one example of how we might not think gender plays a role there, but when you bring diverse perspectives to it, sometimes the gender element comes out.
I wanted to add another example of that, and this question is asked many times. In fact, why specifically for women? And this used to happen much earlier because all the policies were gender neutral. And when people like us and before us, people started asking specific questions, policymakers will always talk about that. And I remember in 2007-8, we were working in Madhya Pradesh, and the officers were really resisting any change in the budget. They're saying, infrastructure has nothing to do with, road is for everyone. Yeah, transportation is for everyone. What have women to do with aviation? What have women to do with defense? Industry. I remember we had a huge discussion on women's role in industry. Now things are changing from there. I always go back to data again and to say, and whichever data is available, and look at our constitution. So, and this is my favorite example, always saying that our constitution is one of the progressive documents in the world. And where are women? We got all the rights, equal rights, when our constitution was drafted. But where are we? Why is there still a 10% gap in education? Why is there a gap in leadership positions, in judiciary, in political representation of women? There is gap everywhere. If everything was equal, neutral policies could serve the purpose, we would have been equally there in number there. But we are not there. So data comes to our rescue in these situations to influence, and also having more women in leadership positions always helps too. I'm not saying all women are gender sensitive. There are some men who think forward and bring these policies there, but numbers do matter. They are able to speak more if they are in critical numbers there.
Thanks so much to Michelle and Kanta. I'm going to ask maybe our representatives from Sri Lanka or Philippines, if you want to respond to the question around private sector data and how are you addressing it in your
Yeah.
country?
Yes, thank you. I'm from Sri Lanka, as I said earlier. So, when we look at the Sri Lankan health system, in-ward care is 95% provided by the state. But when you take the ambulatory care or the outpatient care, it's like 50-50. So, I hear what you say very well, because there's a huge service component provided by the private sector. But fortunately, we do have a private health sector regulatory council, and all the major private health sector providers are registered there. I'm talking, that is the inward care, the private hospitals. There are issues about OPD or ambulatory care providers in the country, because we have this dual practice. I can even do a private practice of ours. So it's very complex, but regulatory wise, laws wise, we have the act and the council established, but there are issues in implementation, but it's been progressing actually very well. We have a devolved system where there are 9 provinces, and the provincial health director has the authority to implement the act. It's very complex. Getting data is the second step. First, registering them. If we register all private sector providers, we can very well incorporate them into the same system of surveillance, because our health information systems are developing now, digitalizing gradually. So it is possible to do, but I would say still at a very infancy stage. Thank you.
Thank you. Adriel, anything on it?
I may just have a quick rejoinder on what ma'am has mentioned. So in the Philippines, we have the universal healthcare law, and a key component of that law is the discussion on health information systems. So in the Philippines, there's not just like one big system that the private and public sector are implementing. It's usually we're talking about numerous operating systems that are for some time and way back are not even talking to each other. So we had a difficulty there in terms of collecting the data to improve our metadata for the indicators for gender. So what we're doing there is to ensure that, number one, you have a health information system that is ideally talking from across different information systems, because it would be really tedious and difficult to have that data if the private facility cannot upload or submit to that information system. And second, I think what we've learned in this recently concluded workshop is the data is never going to be complete. There's always room for error. There's always going to be facilities maybe under the private or the public sector that won't be able to report. But with the data that you have, it's perfect. What you can do though is to find a way that you can still use that data to advance gender mainstreaming, not just in health, but also in other sectors. Thank you.
Thank you, Adriel. We have a question from the chat, so I'm going to try and give the online audience some space as well. So the question is, societal change, especially in the younger generation, is influenced by the education standard or norms that are taught and accepted in school systems. How involved has the education sector been in these gender mainstreaming policy discussions? And excuse me, I may say the name wrong because I can't read it very well. I think it's from Ruvani Chandrasekhara. I hope I said the name correct. Anyone wants to take that question, looking at the education sector and how we sort of influencing change even in the younger generation? Ravi, I feel like I have a feeling like you can respond to this.
Thank you for asking this question. I assume that perhaps the idea is to know how education sector intersects with the health sector, because that would be key to this discussion. I think there are many different sectoral efforts that are that are promoting gender discussions in their own ways. But point is, how do they intersect with each other or connect with each other? That's more important. And I think educational, within India at least, I have seen, and I think globally, the interaction between health sector and the education sector is most vibrant, because school education programs or health education programs within the school system allows an entry of health system to be operative within the school system. And now, coming back to the education system, its own capacity to absorb and be upfront about gender issues is something that has suffered from the similar kind of weaknesses and challenges that any other sector suffers. Because, and what are those? One, that at least in some part of the world that I work in, India including, which believes in a very hierarchical system of knowledge creation and knowledge production and knowledge dissemination, does not allow the knowledge to become more diversified and inclusive in the children. So bringing any discussions around gender within the school system means challenging the foundations of how education, how learning and learners are treated within that four walls. And our teachers are taught, or pedagogy itself is not really conducive to doing that participatory and engaging and bottom-up kind of understanding of how knowledge gets understood by the children. So school system is far more challenging in my view. And early age, I think Michelle at some point mentioned that the children we have to begin from there. I couldn't agree with that more. For last 20 years, ICRW and partners have been engaged in a very intensive program called Gender Equity Movement in Schools, GEMS program, which has gone beyond India, working in Bangladesh and Vietnam and many other countries. Our program is up there for anyone to download and use it, and we are very happy that there are many who are using it. I do not know what is the capacity of those who are delivering those interventions, because the ones who deliver the school education gender program within the school have to be far more sensitive on this. Our experience shows in the school, we are currently working in about 400 schools in Jharkhand. We work in 9 unions in Bangladesh. Bangladesh government has scaled up that GEMS program within their Generation Breakthrough program, and it is being delivered from the most religious outlets also, talking about gender. So there are good examples with mixed bag of results, and a lot depends on how school as a system responds to this. Always it's a systems change that we are talking about. These interventions, when they are done within the schools or within the health system, they should be seen as not a downstream fixing disaster mindset kind of a approach, but upstream. And I'm just taking the opportunity to respond to that first question, that private sector or the health sector, which is largely tertiary oriented, has moved away from primary health care programs, and that the whole idea of we have de-linked prevention from the treatment and mitigation. We constantly are doing a kind of a firefighting on health issues. It's not so. I mean, we must be preventive in our approach. We must link prevention with treatment, mitigation, and cycle of that. And that's not happening. Major funding that goes into health infrastructure, that goes into infrastructure projects, school projects, they only look at those downstream kind of outcomes. So my sense is that we need to connect prevention and primary health care has to be the foundation on which the school education programs, health education programs, they're all built in, not from a disaster firefighting kind of a mindset.
Thanks. We actually at the end of our Q&A session or time, but I'm wondering if I'm going to take a few questions, and when I'm going to hand over to the panelists to make their closing remarks, If you want to respond to the question, a question very, very briefly, you could do that. So I know there's been a few hands. You had a hand and you had a hand. I'm seeing a lot more hands now, lots of enthusiasm. The panelists will be here for lunch, so you can also engage with them during lunchtime. Grab them as they're eating. They won't be able to move away from you. Yes?
Yeah, thank you for having this discussion. It's
Your
very
name and where
useful.
you're from.
My name is Kriti, and I'm working around the idea of providing accessibility to the waste pickers community for health services. So my question here is for emergency services. I understand that we are focusing on primary and secondary services, but what at my work I've observed is that women are also very much vulnerable on understanding the idea of accessibility for emergencies, like pregnant women not able to reaching out to a hospital or something. So since we are also talking about data, like what data says about it, about how much events of death and accidents happens when they are not able to access emergency services. Thank you.
Thank you. I'm going to take two from the audience, so the two in the front, and I have two from the online audience as well. Sorry.
Thank you very much. You know, the question about the private sector and the public sector. In terms of treatment, I think the private sector is streets ahead of us. They have the data, and if you look around, the most hospitals that are built by the private sector, because that is where the money is. There is no private sector engagement in prevention and in awareness. That is the role of NGOs and should be of the government. We keep saying that nobody knows what they should do to prevent disease, but we are at fault for not making sure that that information gets to them. I'm sorry, it's a comment, it's not a question. I think this is the truth in every country. I have to leave just now, so that's why I grabbed the mic.
And we love having comments as well, so we're totally open to having comments. Two questions that came in on the chat. What are the key indicators or metrics that are currently being used to assess the effectiveness of gender mainstreaming efforts? And this was from Dr. Swetangi Shinde. And the second question was, data is one thing, but political will is another thing, to bring data interpretation into practice. What should be concrete actions to bring data into political will? And this is from Han Sovadarak. I hope I'm saying it wrong. Apologies to the person online. So I'm going to ask the panelists to make their closing remarks. And if you wanted to respond to just one of the questions, so choose the one you liked the most, you're welcome to do that at this point as well. So we wanted to have almost like a tweet round, very short comments, almost like 30 seconds or less to sort of close. But if you wanted to take another 30 seconds or a minute more to answer a question, you're most welcome to do that as well. So maybe I'll start with Chloe, since you're the closest to me. Don't look so unhappy about that.
Okay. I think I'll finish off by saying that strong CRVS systems that respond to the needs of girls, women, and vulnerable and marginalized population groups are such a rich source of data, and they hold a key to ensuring that no one is left behind. Thank you.
Chloe wanted to talk last. She wanted to have the last word. Kanta?
Thank you. It's a very important issue, and gender mainstreaming is very important, particularly in the health sector, because women's health is critical to the nation's health, and we need to pay attention to that.
I'm going to respond to the one question from online about how do we communicate the evidence. And I don't think there's a catch-all response to that. I think we have to know our audience within the cultural context, within the sector we're trying to target, and then tailoring messages to meet the audience where they are. if we just talk about gender mainstreaming to an audience like this, we're sort of preaching to the choir, as they say, but you might need to tailor the message to those who are more resistant to that. And so I will just conclude by saying that I'm going to repeat what I said earlier. Gender mainstreaming is a strategic approach, and that's just part one. We need to also then take it to the next level of transforming gender dynamics and harmful gender norms to really move towards gender equality.
Right. Before I end or conclude, I'd like to have a go at the question on metrics. I think when we're talking about indicators, they need to be gender issue based. You cannot have indicators that do not capture the problems occurring at the grassroots level. So I think it's important to ensure that indicators we're going to use are those that are responsive, are those that can be moved by the interventions you have in mind when addressing those identified gender issues. As for my final words, I'll just want to say that gender shouldn't be an afterthought. It's central to justice and especially important when we want to elevate the health outcomes for all. That's all. Thank you.
Thank you. Yeah. I like to also reiterate what I mentioned earlier. It's good to collect data, but it's very important to analyze and interpret data with gender perspective so that we can have very targeted, appropriate strategies in our policies. And I hope that will apply to the second question also when addressing politicians. If we have gender disaggregated data, I'm sure we can develop appropriate advocacy material so they would also understand when we present it in numbers better than just sentences. So that's my comment.
Okay, everything has said everything that had to be said. Well, I think, although I am totally against essentialism, but I really think that data democratization is essential to gender mainstreaming. I'm not using the term data disaggregation because I think the data disaggregation or sex disaggregation again puts it into a very technical jargonized manner, and therefore I prefer to use data democratization. I think data democratization is essential for gender mainstream. My thought.
Thank you so much to the panelists. I was trying to take notes, and it was such a rich conversation. It was difficult to try and take notes and capture, all the sort of information that was raised today. I think data and evidence and the importance of that, there was a strong theme across many of you. It started early on, but I think it continued even into the questions raised by the audience. And we also talked a lot about the different sources of data. Both from the civil registration and vital statistics data to routine data, research data, and then also bringing into account other partners such as private sector data, which often gets excluded. Linked very closely to that was this issue around partnerships and having intersectoral collaboration. So partnerships across the board, it linked again to the issue around private sector, but also within governments and those of us who are working in the same space. We heard a lot about sex and sex disaggregated data, but I think there was also a mention around moving beyond that. So not just thinking about the sex disaggregation, but looking at gender and also other minorities in the space. And I think, as many of us are focusing on gender, I think the underlying sort of issue is we have this focus on equity. And I think, Ravi, you mentioned this intersectionality. It's not just about the gender, but then we also have to look at education, geography, how does this all intersect with each other? And I was thinking about Kanta's example around maternal health and how women's pain is often undermined. And I think in a lot of research coming even out of the US around how women often, not only like women's pain and women not getting the services they require, or not having their health needs being acknowledged, but also seeing that women of certain race groups being disproportionately more affected in many ways by that. So also a lot of thoughts around that. There were some conversations or discussions around investment and looking at the economics around us. I think in two ways. One is how much are we investing in this space, but then also how does economics and investment actually reach a woman and affect women as well. So thinking about it from both sides. And I liked Ravi's comment at the end at one point where he said it's about unlearning, and I think Michelle spoke about this as well. It affects all, gender affects all aspects of our life, but it's almost like we have to unlearn these sort of norms that we have in society around the practices related to gender. So it was very, very brief. There was so much more that was covered. You probably could see me trying to take some short notes as I was sitting here. So thanks to all the panelists for this really interesting morning. I'd like to welcome Alan back to the stage just to give a token of appreciation to each of the panelists. So yeah, do you want to maybe come on? Maybe behind you.
So firstly, thank you very much. To be honest, these kind of conversations are so important, especially for people like us who, are not so aware of all this. I think it's panels like these, discussions like this, that awareness building is so important. And to be honest, for me itself, it was a great learning to hear from you all. What we heard around mainstreaming and how do you unlock new money to do this. Clearly, if you have data, you can actually then go to the government and make that case for what you need. So I want to sort of thank all of you. I think it's a very rich panel with a lot of experience. I think, to my mind, a lot of panel discussions happen and they should not end there. That should be the beginning. And I hope I go back to what I said earlier about collaboration, that these are platforms which should build that collaboration. They should lead us to what next. And to make that happen, I'll welcome any suggestions. We will be happy to broker those linkages, partnerships. I do believe governments will act once we give them that data. And, I think you made a good point around the SDG indicators and the whole CRBS system. So my learning from this has been that we should not leave anyone behind. And this whole advancing of equity, to be honest, we don't even understand what it means. So there is a bias inbuilt in our system. So I think that education can also play a big role. So I want to thank all the audience who are here in person and those who have joined us online to invest their valuable time. I think this is just the beginning of what we all perhaps collectively are looking to do, and many of you have been doing. So thank you very much to the panel, and a big applause for them. I think they deserve, so the intensity with which you enjoyed it will be known by the clapping you do. So no bias in that. So let's give them a big applause. And Roxy, you were brilliant. I was looking at the clock at 12:29. You actually shut your discussion, and then you went to questions. So big applause for you also. Thank you. And okay, this is. Should I start? Ravi, you are in minority here, so I'm. Thank you.
Thanks,
Thank you.
Alam.
You've been brilliant, you know, absolutely.
I
And she
didn't
deserves
deserve
a
one.
special applause also, not only for being remember what we see, but there are a lot of people who worked at the background, and this has been going on for a while. And I'd like to first thank Dr. Nidhi Chaudhary. She's standing here. She's a valuable part of our human capital, intellectual, and also doing great work on the ground. We have Fiza right behind. She's been helping with whatever has been happening. Then I have my other team members, Jagriti, Chaitanya, and Hemant. I don't know if they're here, but Jagriti is right there. Thank you, Jagriti. And who else? And Seema and Arpita, there they are. So you may want to get up so that people know. So Arpita, thank you. And Seema, you've been, she helped me with my talk notes as well. So thank you. So thank you all, and we'll have some lunch after this, and you can interact, and I hope we can take the discussion forward. So thank you all very much.
Thank you. Thanks, everybody. Thanks to everyone online. We're going to log off now. And to those of you who are in the with us, as Ella mentioned, there is lunch. And I know there was a lot of enthusiasm at the back of the room with lots of questions. So as I mentioned, you can engage the panelists during lunch. Thanks, everyone.
And we'll just take a photograph with everyone. Huh?